Welcome to season 2, episode 16 of the Home Healthcare Today show. I'm your host, Dr. Cleman Moore. All right, we are arriving at the end of calendar year 2022. We have the distinct pleasure and honor today to have on our show Dr. Phillip Levy. All right. Dr. Phillip Levy, MD, is a professor of emergency medicine and associate vice president of translational science at Wayne State University. He is the Edward S. Thomas Endowed Professor in the Department of Emergency Medicine, and he currently serves as the vice president, associate vice president, as we mentioned. Right. Dr. Levy is also the director of the Center for Population Health Accountability for Wayne Health. Dr. Levy, welcome to our show today.
Clem, good to be on here with you.
Good deal. Dr. Levy, when we hear the term translational science, do you want to elaborate on that a little bit and kind of define it in layman's terms?
Yeah, absolutely. So translational science is basically an umbrella term for how you take things that are discovered through research and translate them into clinical practice. And oftentimes it is used to describe taking work that begins in the basic science lab, maybe work that's done on a mouse or an animal model, to understand a relationship between some risk factor and disease or some drug and benefit in a condition, and then move that from the bench, as we say, to the bedside. Yeah, it can go the other way too, though. You could see things in the bedside arena. I see this relationship with this condition and want to discover the mechanisms behind that, and it goes the other way. It can go bedside to bench. It could also be, we've done research on this clinical pathway and now we need to move it into policy and actual practice. So it's really just taking discovery and translating it to something that can then help humans, help people.
Wonderful, Phil. I totally understand. Yes. So whenever we think about public health and hopefully on the downturn or the downside of a pandemic that perhaps has gone to an endemic stage in the public health community, how did Wayne Health, move ahead to get those mobile units developed to get out into the community over the last few years to deliver vaccines?
Yeah, Clement, and I would say we are in this endemic phase, and I think we're going to be with COVID for the foreseeable future. But I'm glad you mentioned the mobile units, and hopefully your viewers and listeners have seen these, maybe even gotten services through the mobile units. But basically, the mobile units began very early in the pandemic when we realized the need to bring services into communities, because early on in the pandemic, as we all recall, Detroit was hit particularly hard, had higher caseloads and higher death rates than any other community, and people were scared to go to the hospital. We also had hospitals that weren't equipped to deliver services to not the most critically ill, but to people who were sick or worried that they had COVID, and they had no way of getting the testing they needed or the resources, ultimately the vaccines as well. So we started working on a program with the Ford Motor Company to say, we have data. We created a data infrastructure at Wayne State called Phoenix, which is the Population Health Outcomes and Information Exchange, which is a way to integrate health data with social determinant or social factor data and understand at a neighborhood by neighborhood level how those two things come together.
Yes.
And realize that we were seeing a lot of communities surrounding these hospitals like Sinai Grace Hospital that were bearing the brunt of the pandemic early on, that had elderly individuals, high social vulnerability, and needed someone to bring care to them because they couldn't get to care. Absolutely. They were unable to go to the hospital. There are various reasons for this. And so we started working with the Ford Motor Company to deploy vehicles into those communities, initially targeting COVID testing and then ultimately COVID vaccinations. But along the way, we realized we could do so much more. We can go beyond just COVID, and we can think about all the other factors that make people more susceptible to consequences of COVID. So
Yes.
said another way, COVID didn't have a predilection or doesn't for Black versus white people. The
Right.
problem is in a lot of areas of the city of Detroit, you have individuals who have risk factors for health, like high blood pressure, diabetes, high cholesterol, that don't have ready access to the care services they need.
True.
That means that they start to develop consequences, what we call subclinical consequences, and haven't yet felt them, right? So
Yes.
blood pressure's high, you start to develop some damage to the cells of your kidneys. You haven't needed dialysis or anything. You would never know this. Then all of
Right.
a sudden, one day you're not feeling well, you go to the hospital and they say you need dialysis. And you're like, what
Exactly.
the hell are you talking
Right.
about? That's
Exactly.
all the accumulation over time of these micro insults from these conditions.
Yes.
The population has a lot of that. You layer on something like COVID on top of it, big hit to the body, big stressor to the body.
Yep.
People whose bodies have been damaged over time in a subclinical way can't handle it. And so
Absolutely.
we realize that it's not just enough to test people. We got to look at what else is going on. So starting to measure blood pressures and drawing lab tests, blood work, right, from people's cars, right? Sticking your arm out the window and our team's
Yep.
there drawing blood to look for kidney damage, to look for early signs of diabetes, to look for high cholesterol, and then delivering the services, linking people to the care that they need. That's
Yes.
really where this all started building out. And not just the medical side, the social side as well. Asking
Absolutely.
people, do you have enough food on your table? Can you
Yes.
pay for the resources? If you need medications, can you pay for them? And then having community health workers there to help deliver those services. So really,
Wonderful.
we built out this vision to say, access is a challenge. We
Yes.
can deliver services place-based going forward. And maybe we're onto something, not just during the pandemic, but beyond.
Absolutely. Definitely, Dr. Levy. So my mind goes back as you talk about Sinai Grace and the communities. I'm a native. I grew up in the 48227 zip code, and I can remember my parents seeking healthcare services from, at that point, Herman Kiefer. So I remember you coming to Wayne State 2002. Herman Kiefer was still around.
Yep.
And then as a kid, I got healthcare services at Gloria Bigham. And hey, so Gloria Bigham Health Clinic, Herman Kiefer as a hospital for adults who had either Medicaid or were low income Detroiters. But now, to fast forward 20 years, to see that there are more service providers that are making themselves more so localized, even if it is via mobile units. And then to your point, connecting to resources. So other, social resources, Forgotten Harvest, gleaners, food, mental health, counseling, and the like. All of those are very, very invaluable.
Vision services too, right? Which I
Yes,
know
sir.
is near to your eyes and your heart.
Absolutely.
It's really, it's about trying to really make this patient centric. So we
Yeah,
throw that term around a lot in medicine, and there's been
we
a
do.
movement in the last 4 or 5 years around patient centric care.
Yes,
However, the system is hospital centric.
it
And
is.
so when we say patient centric, it's how can we make your experience better at the hospital, but you still got to come to us?
Yeah.
Or how do we make your experience better in my clinic, but you still got to come to us?
Yes.
Right. And so how do we change this so that we come to you and do it in a way that doesn't require the physician to be out there?
Exactly.
Right. We want to come into a community and screen people and look. We don't need a doctor on site to do that. I don't need a doctor on site to measure blood pressure, to ask you, do you have enough food on your table, or to help you get your prescriptions paid for. We need other service providers. And so we're looking at this system now of deployment of mobile units to communities at high risk. And saying the most important thing is not that you see the doctor, but that we reach you.
Exactly.
Find out your needs and then figure out the way to deliver your needs on your terms.
There you go. There you go. And a industry, such as healthcare, that is so comprehensive and so many moving parts. So to your point, Dr. Levy, about a patient-centric approach in theory that is facility-based, now moving to patriot-centrism, take away the quotes, and then localizing it within the home or the community or the neighborhoods that people live in, game changer. Other industries have done it. We've seen it in food, Grubhub. We've seen it in entertainment with Netflix. I'll customize a stream just for you. But without health and wellness, how valuable are those quote unquote, services, right?
Yeah, you see Amazon. Amazon's everything right now, right?
Yep.
Amazon is employing a lot of people and they're paying
Yep.
it back by bringing resources into communities, but it's all built out of the idea that people want what they want the way they want it, where they want it, when they want it, right?
Yep.
And we can think of healthcare not in the same commodity,
Right.
mindset, but the same delivery mindset. And now
Absolutely.
Amazon has regional centers where people can go because,
Mhm. Yep.
porch thieves and porch pirates, grabbing packages and stuff is a problem.
Exactly.
But the point is that making things convenient for people
Yep.
has proven successful.
It
Period.
has.
That's it. Period.
Absolutely.
And
Absolutely.
if we continue to think of healthcare as effective when we have to inconvenience people to access it,
Yes.
we're going to be sorely mistaken.
Absolutely, Phil. Dr. Levy, what are some of our barriers as healthcare providers that want to localize, we want to deliver it? Are the payers catching up to us? Is the infrastructure in place yet to, aid us? Or are we, finding ourselves still trying to drive home the argument about wellness and being proactive and the value of being on the front end versus the deferred expense, and then the greatest expense, a decline in health or folks not getting the care that they need because of some of the antiquated approaches
Yeah.
to our delivery. Yep.
Yeah, I'll say,
Yep.
first and foremost, we're lucky that we live in a state that is forward thinking.
Good.
So early on,
Yes.
we were the first state and one of the only states that developed a racial disparities task force to try to understand why the brown and black communities were being disproportionately impacted by COVID.
Yes.
We also had people in leadership roles within that task force, myself and others included, who started to do innovative things, and we found receptivity to new thinking, right?
Yes.
A lot of people, when the pandemic hit and things started to change, in the medical community kind of longed for the way things were before, right?
Yeah.
We want to let's just keep things the way they are and it'll be okay.
Right.
But the reality is that didn't work and it won't
Nope.
work. Right.
Exactly.
People couldn't go to their doctor to get a COVID test. They couldn't go to the doctor to get their first vaccination.
Yep.
People had to use available community-based resources, which worked very well. High throughput testing locations and vaccination locations worked terrifically. And it made it convenient and easy for people to get that. You didn't need to make an appointment. 4 weeks later, you finally get in. You sit in a waiting area for an hour. Take to the back of your doctor for 10 minutes because they're so busy charting on the computer. And then maybe you get some blood work ordered where you have to go to another location. And then a month later, you finally get the result. I mean, that is archaic, right?
Very much so.
In a system where I can get a package delivered that same day from Amazon, I'm
Come
still
on.
getting healthcare like it's, the 1950s.
Exactly.
So how do we change that? The state really espoused this, took the vision that we had started at Wayne State, built it up as a pillar of that racial disparities task force, and is now looking for sustainability models going forward. And yes, the payers are on board.
Good.
Why? Because the payers realize that they hold the coverage for many people who don't actually use services.
True.
Why don't they use services? They're not bad people, right?
Nope.
They're just busy. Everybody's busy. We have jobs, we have families, we have obligations.
Absolutely.
And if we make healthcare and access to services, especially prevention services, readily available where you live, work, play, or pray, that's a game changer.
Yes,
right?
It is.
Oh, I'm driving home. I just picked up dinner. Oh, why don't I stop by that mobile unit I see right there? No appointment needed. Get my blood work done, get my blood pressure screened, and then the team follows up with me. Why not?
Why not? Why not? Absolutely. That is the question, Phil. But we're answering why not. There's no good reason, and we are developing the future that we want and need for folks. With that being said, Phil, what does that future look like as we wrap up? I mean, will there be drone delivery of durable medical equipment as well as pharmaceuticals? What are we looking at?
We've explored, drone delivery of Narcan, right, to communities where, someone's experiencing an overdose. Instead of sending an ambulance, deploy a drone out of a mailbox or something like that right to the community. That's potentially future state. But in the meantime, getting people to understand that they have to play an active role in their own healthcare and their own wellness, and getting people not to see illness as inevitable, not to say it doesn't matter if I prevent something because the system will fix me.
Absolutely.
The system itself is broken.
True.
Right? Anybody who's been to the hospital in the last 2 years can see this. It's a mess. People are fed up with how care is being delivered, how care is being received. And so let's say if the system's broken, let's fix it, not keep throwing, boards and planks on top of it to make it look better. Let's fix the system. And I really think the future of healthcare is one where prevention services are ubiquitously available, cost-free, barrier-free in people's neighborhoods. That information is shared with providers who ultimately, may need to care for this individual when problems are identified. People can get all of their care in the community where they live. We can give you blood pressure cuffs and scales and glucometers if you have diabetes, and all that information can be beamed up into, the electronic health record. And community health workers, which are trained community members who see the world, live the world the same way as the people they're trying to help, can become primary caregivers. It's not about physicians, it's about a team. It takes a village, Hillary Clinton said years ago, and that's the reality in medicine. It's going to take a village of concerned and caring individuals who want to meet the needs of the populations and work together to solve big problems.
You got it, Phil. Last question for you. The energy is contagious. I told you that from day one. The impact is felt, and it is greatly needed. Biggest accomplishment, Phil, of 2022 in this space, and then the biggest hope or goal for 2023 for the greater community of Detroit out there, because my homebound listeners and readers, they need to know.
Yeah, great question. So I think the biggest accomplishment of 2022, and maybe leaking a little bit into 2021, is the receptivity to this model that I've experienced, not just from the patients, right? We've now done more than 83,000 encounters in our mobile settings across the region. We've done almost 2,500 events. People have spoken with their feet or with the wheels of their car pulling up to our locations. But the other side is that the payers are now interested in this.
Good.
Organizations that fund these type of efforts with grants like the American Heart Association, the National Institute of Health have bought into this. We've received tremendous grant funding. It's been almost $50 million in grant funding that we've received since we started this in 2020. A lot of that has come on in the last year. So it's been successful to help build this out. My hope for 2023 is that we can continue to grow this, that we can create this infrastructure across the state, use shared data to deploy vehicles, and use this resource to keep people healthy in times of non-pandemic needs, and then have something that can be flexed and ramped up immediately when a pandemic or something hits or the need arises, so that we don't have to be caught flat-footed and people don't have to suffer because the system wasn't ready. Let's make the system ready and then put it in place.
Amen. Hey, good stuff, Phil. As you alluded to earlier, what Hillary Clinton, repeated from the great Maya Angelou, it takes a village. Do know that, hey, folks like us at American Advantage Home Care, as well as I Care for Detroit, want to continue to be like a partner alongside you guys in the community, doing great work for the folks that need it and matter the most to us. Hey, Phil, wishing you the best holiday season for you and your family, and we really appreciate all of your contributions, what you and your team are doing for Detroiters. We love you and appreciate it.
Likewise, Clem, and happy holidays to you and all your listeners and viewers, and I look forward to working with you for many years to come.
Absolutely. Fantastic. Thank you, Phil.
Thank you.
We are beating the pandemic here in Metro Detroit. But to no surprise, there's another cold, bitter winter season ahead of us. Thus, allow American Advantage Home Care to come into your home to provide safe, high-quality, skilled nursing and physical therapy services. Choose a home health care team that never, ever
drops the ball.